Being recorded.
Okay, so we are going to start officially. One, two, three. Hello and good evening. I am your host, Reeanna Harrilal, President and founder of the Voice of Lupus Foundation. Welcome to the Voice of Lupus Foundation's Let's Talk Lupus webinar series. This educational initiative is 3 years old and seeks to empower lupus patients throughout Trinidad and Tobago by providing them with knowledge, education, and practical solutions to deal with the brutal impact of living with lupus and to better understand the disease. As you know, I am a lupus warrior and an advocate. I am happy that through the Voice of Lupus Foundation, we can facilitate this session for the benefit of all lupus patients here in Trinidad and Tobago, their family members, caregivers, everyone, friends, to better understand what living with a chronic autoimmune disease is like. The Voice of Lupus Foundation is a registered NGO fiercely committed to quality of lives for all people living with lupus in this country since 2011. We accomplish this by investing in initiatives, hosting events, programs, and planning campaigns that promote advocacy, awareness, public education, and support for our patients. The Voice of Lupus Foundation's mission is quite simple. It's to give lupus a voice through programs of advocacy, public awareness, education, and caring for and improving the lives of people living with lupus. Our vision, a world where people with lupus can thrive and live full and active lives. Our core values, some of the core values in improving the lives of people who have lupus. We believe that every lupus patient is entitled to the best possible information and other resources about their condition. We believe in advocating and educating the public and the medical fraternity about lupus and its devastating effects. We believe in bringing people together with lupus so that they are not isolated and they are empowered. Also believe in listening to those who have lupus who want to talk about their journey with living with. Well, today our webinar will discuss common diseases that overlap with lupus. Now, exactly what is lupus? Now, I'm not Dr. Keisha Davis King, but just to educate the public who's listening, lupus is a chronic long-term disease that can cause inflammation and pain in any part of your body. It's an autoimmune disease, which means that your immune system, the body system that usually fights infections, attacks healthy tissue instead. Now, lupus most commonly affects your skin, joints, internal organs like your kidneys, lungs, and heart. Because lupus affects many parts of the body, it can cause a lot of different symptoms. Now, it is still considered a cruel mystery. It's quite unpredictable to determine from patient to patient which types of healthy tissue might become inflamed or when. In fact, almost any organ can become inflamed in some patients. Now, some patients only inflammation in the skin and joints, others in multiple areas. In some cases, lupus manifests in only one part of the body through the most common examples that are rash or decreased blood cells. In these cases, a doctor may use the term to describe the illness. Now, common diseases that overlap with lupus are autoimmune thyroid disease, celiac disease, myasthenia gravis, antiphospholipid syndrome, also known as APS. And I know a lot of our patients also have APS. Many patients talk about their struggles with thyroid issues, rheumatoid arthritis, myositis, dermatomyositis, scleroderma, syndrome. Now, there are also many less common autoimmune diseases that can affect people with lupus. Overlapping diseases are most likely to develop shortly after the first diagnosis, whether you've just been diagnosed with lupus. There is no limit on when a second or overlapping autoimmune disease may develop. although it is most likely to happen shortly after the first diagnosis. Nevertheless, it is to develop a second autoimmune disease more than 10 years after the diagnosis of lupus or another autoimmune disease. So it's important to keep the lines of communication open with your healthcare provider to discuss all the symptoms you are experiencing and to ensure any potential overlap diseases are recognized. So, without further ado, to lead us to understand more understanding lupus and autoimmune diseases is Dr. Keisha Davis King. Dr. Keisha Davis King is a consultant rheumatologist and medical internalist at the Eric Williams Medical Sciences Complex. A lot of you might know Dr. King personally because she's your doctor, just like me. She's my doctor fondly. And she has over 10 years of clinical experience in internal medicine and pursued her subspecialty. Dr. Davis King also has professional affiliation with the British Society of Rheumatology and is currently the president of the Caribbean Association of Rheumatology with the aim of increasing awareness of rheumatological conditions among the general population by providing a high quality of care for patients utilizing the most medically now, Dr. Keisha King, not just beautiful, but lots of brains. She's a graduate of the University of the West Indies, where she received her MBBS in medicine with honors, and she then also completed her rheumatology fellowship in rheumatology, that's RCPE, and specialty certificate examination in the United Kingdom. So, Dr. King, welcome to the Voice of Lupus Foundation.
Thank you, Reeanna. Thank you for having me. Okay, well, today, the topic we decided on was overlap syndromes and undifferentiated connective tissue conditions, right?
Yes.
It's a short presentation, so I'll introduce the topic, and we have the floor of questions, which I imagine we have a
Yes,
lot of.
I do.
Yes?
Before the webinar began, I fielded a lot of
All
questions
right.
from patients. So I know a lot of them want some questions answered.
All right, let me share screen. Are you all hearing me clearly? Can you hear me clearly? Yeah?
Yes, I can hear you good. Yes.
All right, so we'll start off with rheumatic conditions. The topics we'll be discussing is undifferentiated connective tissue diseases, as well as overlap syndrome. And I'll tell you why they're important. As many of you are well aware, 25% of rheumatic patients with systemic symptoms cannot be definitively diagnosed. I'm sure you're well aware of the frustrations that you all may face of having some time pass before actually making a concrete diagnosis.
Yes. Dr. Kim,
However,
before you continue, can you enlarge in the screen or full screen feature?
let me see.
Yes.
What exactly are you seeing? Because for me, I'm seeing the entire PowerPoint.
Okay, it's showing very small on your end. On our end, we're seeing it small. On my end, I wonder if you can use the full screen feature.
I do have the
You may be
slideshow.
sharing the wrong screen.
Can someone provide some technical advice here?
Let me try again.
Okay, select from the beginning. Okay.
Is it me sharing the wrong screen or yeah?
Yeah, it would be you.
No, I'm sharing it from the window.
Okay.
Oh wait, let me see entire.
For those of you who are identifying yourselves only with your device, I'm kindly asking that you please put your profile name, your full name on your profile, please. Thank you. If not, you will be removed. Galaxy A02, kindly put your name, your full name, please. Thank you.
Is this better now?
Okay, it's starting to, we're not seeing anything just yet.
Anything or?
Yes, better.
All right. Thank you again. All right, so we'll start again. So the topic we'll be discussing today is undifferentiated connective tissue conditions and overlap syndromes. Yeah. As I stated previously, 25% of rheumatic patients with systemic symptoms cannot be definitively diagnosed. So that's a quarter of patients, which is quite a lot. Remarkably as well, majority will remain undiagnosed during first 5 to 10 years of follow-up as things evolve. Historically, we have used terms such as collagen or connective tissue disease, which we still use, which basically highlights an entity or patients with similar clinical and pathological features of widespread inflammation. Subsequently, as the specialty has developed and become more sophisticated or finessed, we have opted to use terms such as diffuse or undifferentiated. Overlap conditions is a very specific term for rheumatic conditions where there are two or more specific recognized clinical entities. So how do we diagnose rheumatologic conditions? So a lot of it, as I tell patients, is what you tell me, what investigations we have done, and how much I'm convinced that it is what it is, right? And I say this because the guidance that we have as clinicians are really classification criteria. Classification criteria are very different to diagnostic criteria. What it means is a group of physicians or governing bodies, ACR being the American College of Rheumatology, and EULA being the European League Against Rheumatology, sit amongst our counterparts and they decide that certain blood tests, for instance, ANA, let's use lupus as an example, and certain clinical features, if we have a subset of patients with these features and these blood tests, we can infer that they can be classified as lupus, but not necessarily diagnosed. So a lot of it is dependent on the history that we have taken, interpretation of the blood results, and interpretation of the patient that is in front of us. Of course, as all things in life, there's nothing that's absolute. If we were to just stick to classification criteria, we would lose or miss patients with unique features that are not typical for a classic picture. Some of the clinical scenarios that gives us a bit of flavor of connective tissue condition, but not necessarily diagnostic or as I would like to say, a bang door diagnosis would be Raynaud's phenomena, which is the bluish discoloration in hands. It can occur in normal patients and people without connective tissue disease, and it can occur in patients with connective tissue disease. Early inflammatory arthritis or joint pains for patients, however, who doesn't fit criteria for rheumatoid arthritis. Non-specific rashes, which looks like one of the, like say for instance, a lupus rash, but with no lupus features, and multiple non-specific clinical or serological abnormalities. And what that basically means is, which happens to me relatively frequently, we'd be referred a patient with abnormal blood tests and beg to ask the question, what does this mean? Is it significant or is it not significant? Another clinical entity that I see quite common is interstitial lung disease, or what we call non-specific interstitial pneumonia. Say, for instance, you'll have a patient who presents with shortness of breath. Primarily, they would present a lung specialist. They'll have imaging done, say, for instance, a CT scan, and there are particular features that, are you hearing me or are you getting that echo as well?
Getting an echo.
I'm not sure what changed. Nothing changed on my side.
We can hear you now.
All right. So as I was saying, patients may have CT findings of what I call scarring or changes or infiltration on the chest X-ray that gives us an idea that this may be an autoimmune condition. However, they may not have any other clinical features other than lung at that time. And they may have, say, for instance, an abnormal blood test. So these are what we classify as undifferentiated connective tissue disease. It's a disease that diagnosis that I make relatively commonly, right? As I mentioned earlier, these patients do not present with a clearly defined autoimmune or rheumatologic syndrome. They may have overlapping features of two or more conditions, and is estimated to comprise 15 to 25% of tertiary rheumatology referrals. And what I like to tell my patients, again, for these patients who are not fully expressing features of a rheumatic condition, three things can happen. As time progresses, you can evolve into a definitive connective tissue condition such as lupus, scleroderma, polymyositis, dermatomyositis, Sjögren's, etc. It may resolve on its own, or it may persist in this undifferentiated manner. I know sometimes it can be frustrating for patients when seek a physician and you're asked, what is my diagnosis? And you're given this diagnosis of undifferentiated. And some people believe, but it is in itself a diagnosis. It is a known entity. And the reason why it's better to stay broad and to continuously keep looking for evolution of another condition is because a premature diagnosis of one of the discrete rheumatic conditions does not serve the patient well, right? And evolution can occur early in the course of presentation within the 2 to 5 years. So in the majority of cases. So a lot of these patients we keep, once I've made the diagnosis of undifferentiated connective tissue, I'll always be looking to see if there's anything else that may be emerging at a given time. For overlap syndromes now, these are patients with manifestations of more than one discrete systemic rheumatic syndrome. And there are many, many rheumatic conditions. And at any given time, there are two conditions or more could overlap. There are some, because they occur so frequently, they've been given casual names, for want of better words. So for instance, rheumatoid arthritis and lupus overlap is known as lupus. Systemic sclerosis and dermatomyositis is called Sclerodermatomyositis. And one of the newer entities within the last, I would say 10 to 15 years, which is a well-known overlap syndrome, but has been classified as a condition in itself, is mixed connective tissue disease. Mixed connective tissue disease is a patient who has a bit of flavor of lupus, scleroderma, and myositis. Why is it important to know overlap rheumatic diseases? Because these patients differ in certain ways from a single diagnosis. So there was a retrospective study that showed that, for instance, lupus patients tend to develop manifestations sequentially. And what that means is at a given time, you may have a diagnosis of, say, RA, rheumatoid arthritis, or lupus. Let's take lupus, for instance. You may have a diagnosis of lupus. We are well aware of the fact that arthritis is a common feature of lupus. However, we do not expect to see what we call erosive changes, which is bony degradation or erosions in a lupus patient, right? It's more classic for rheumatoid arthritis patient. So if, for instance, we have a lupus patient who arthritis is persistent with erosive changes on x-rays, and we always consider if this may be an overlap lupus and rheumatoid arthritis. And bear in mind that it occurs sequentially and not at the same time. There are certain antibodies, as most of you are well aware, that we look for. Anti-CCP being somewhat specific for RA. So in these patients who anti-CCP antibodies may be present, we may think that this may actually be two separate entity conditions like lupus and rheumatoid arthritis that may be occurring in one patient. Yeah. And sclerodermatomyositis, however, tend to have simultaneous presentation. I have a few patients like these who would present with the skin changes as well as associated muscle weakness more from the onset of time, versus scleroderma patients within the first, their very clinical courses usually within the first 2 to 5 years. Once they've surpassed that hump for all intents and purposes, and this is very broadly speaking, things tend to stabilize. So if you have a patient with early muscle weakness and scleroderma features, we think, okay, this may be an overlap between scleroderma and dermatomyositis. So how do we approach a patient? Why is all of this important, right? As I always like to reiterate, the manner in which we decide to treat is basically based on the clinical manifestation, and it's not necessarily based on the diagnosis. For instance, two lupus patients may not be the same. If your primary manifestation is, say, joint pains, you may be on a course of methotrexate, etc., because we know certain immune medications work better for certain clinical scenarios. For instance, if a lupus patient has inflammation in the kidneys, we know methotrexate does not work for that, does not work in that scenario. So CellCept may be the preferred modality. And just mentioning, I thought it was worthwhile mentioning, there was an intriguing report that stated that the importance of vitamin D supplementation for patients with unspecified rheumatic disease who are deficient. And there may be improvement in the underlying immune system and function, suggesting that continuous vitamin treatment might inhibit transition of undifferentiated to defined rheumatic condition. And finally, some data suggest that hydroxychloroquine may prevent or delay progression of lupus, and this may be an option for select group of patients. This is also an option that I usually exercise or utilize in some of my undifferentiated connective tissue, depending on how significant the clinical features are at a given time.
Dr. King, before you continue, hydroxychloroquine,
Yes.
is it, you mentioned those with connective tissue disorder, right? Mixed connective
Mhm.
tissue manifestations. What are the data for those living specifically with SLE? Is it known to really, really help to prevent, the disease
Progression.
progressing? Yeah.
It's uncertain for me to say the exact data, but on all our guidelines and all the bodies, it doesn't matter which conference you go to, all rheumatologists agree hydroxychloroquine is what we call like our anchor drug, our base drug.
Yes.
We say this because although the exact mechanism is not fully understood, it has beneficial or benefits with respect to cardiovascular benefits, and also it does support some of the other medications that we use. So once tolerated, it would usually be the first line um, that we'll try to get on board. So if you see hydroxychloroquine, say at the center of your treatment plan, and then we add on accordingly. On
Yes.
the flip side, as you add on accordingly and say you attain your ultimate goal is hope is to attain remission, we would scale back on the others and leave hydroxychloroquine as the last to de-escalate. So I think of it as like one of the anchor drugs, and particularly for lupus and these connective tissue diseases. Um, I know sometimes people reference connective tissue like RA, which rheumatoid arthritis, which we use, but I'm talking specifically for like lupus, mixed connective tissue, and well, actually those in particular.
Okay,
Yeah.
okay, okay. And one other point, I remember during the pandemic when there was a really global shortage, I remember us interviewing one of the medical doctors that actually with the drug company that produces hydroxychloroquine, and he talked about
Mhm.
the benefits of hydroxychloroquine for diabetes as well as to prevent issues with the heart, with lupus affecting the heart and
Yes.
stuff like that, you know. So just wanted to, I guess, reiterate that the drug hydroxychloroquine is very important for the management of, our condition.
Yes, it is very, very important. So almost all my patients, if I could get them on and it's tolerated, I like them to be on hydroxychloroquine. Of course, there are side effects as with any medication, so some people are unable to, but it's usually our anchor drug. And it's also relatively safe in certain scenarios, like patients who may be acutely unwell, but you want something on board, but you cannot use one of your stronger immune suppression. So it is not severely immune suppressing like some of the others, um, but it's a good option to have on board because of the, as you mentioned, the cardiovascular and those benefits.
Okay, all right. Thanks so much for answering that question.
No worries. And this is just a table showing undifferentiated rheumatic diseases and overlap syndromes. So mixed connective tissue would be our classic overlap syndrome, as I mentioned before. It's overlap between like lupus, scleroderma, and polymyositis type picture. Then we have undifferentiated systemic rheumatic disease, which we also reference as undifferentiated connective tissue. Non-classic systemic lupus patients. These are patients who gives us a flavor of lupus. They may have the positive antibodies, but have met full classification criteria. Non-classic rheumatoid arthritis, non-classic scleroderma, and overlap syndromes like rheumatoid lupus, which is lupus, as mentioned, scleroderma lupus, scleroderma rheumatoid, polymyositis overlap, juvenile idiopathic arthritis, and even Sjögren's. So this is an algorithm for diagnosis and management of these systemic rheumatic disease patients and overlap syndrome. So when we have clinical consultation, the first thing we ask is, does this patient meet current classification criteria for a single specific rheumatic disease? If they do, yes, we go through a traditional evaluation, monitoring, and management. And if we're not sure, if it's not banged door, then we look for overlap syndromes like mixed connective tissue, lupus, as you mentioned earlier, antiphospholipid syndrome. And once we figure out, okay, um, we start management. And then this is when nuance comes in now. And there are patients who we have one or two criteria, and then you determine if you need to treat or if you need to watch and wait. And this is very dependent on risk benefit ratios. As I mentioned before, all medications have side effects. So this is where you have an active discussion with your patient, discuss that, you're getting a flavor that there may be connective tissue conditions. Is it that you're willing to try a medication to see if we can have, assist in management of your symptoms? However, with closely monitoring and managing expectations in terms of what outcome we're looking for. So, in summary, as we're well aware, rheumatic condition can present with many symptoms. If you have a patient in front of you who doesn't fit a classic rheumatic condition, always consider undifferentiated connective tissue. It is always better to leave it broad and narrow down as clinical features or scenario change, and always consider overlap syndromes. And treatment is based primarily on clinical manifestation. That's it for me.
Short and sweet.
Yeah.
I have a question from someone whose mom is a lupus patient. He's asking the question: is prednisolone safer than
Mhm.
hydroxychloroquine? Or hydroxychloroquine is safer than prednisolone?
So that's a tricky question to ascertain. As I usually say, all medications have side effect, right? And our ultimate now, prednisolone works nicely in terms of what I usually say is prednisolone settle things quickly, if we can, and there's a place in terms of bridging. But prednisolone is never your ultimate aim to be on prednisolone lifelong or indefinitely because of the side effects that can occur. Hydroxychloroquine side effect profile is much less than prednisolone used for a longer period of time. And hence we use to consider for rheumatic conditions, or what we reference sometimes as steroid sparing. And the reason being is to ultimately get you off steroids.
Okay. Moving to some of the questions that were submitted earlier in the week concerning our session. Someone wanted to ask the question, how does lupus differ from arthritis? I know you went through the classifications, but in layman terms, for someone listening who has lupus or might have RA, what is the difference? How does it differ?
So arthritis, as the word basically means inflammation in the joints, right? Lupus, you can have inflammation in joints with lupus. Now, when we look at arthritis is a very broad term. As I said, it means inflammation of the joints. I look at it two ways when explaining to patients. One is inflammatory type arthritis, where rheumatoid arthritis, psoriatic arthritis, all of these fall under spondyl. A lot of these, even lupus, right? And there's mechanical or wear and tear arthritis, where we reference osteoarthritis, right? RA is a particular type of rheumatoid arthritis that involves small joints of the hands with and it can have erosive changes, which is joint destruction, if not treated aggressively early. Lupus, we don't expect, I mean, this is not absolute, we don't expect significant joint destruction with lupus compared to rheumatoid arthritis
Okay.
or erosions. So,
Right.
and with all these arthritis, if you look at x-rays, you have particular nuance changes that you would expect that differs from these arthritis.
Someone wants to know if general if general arthritis is different from lupus arthritis. I wonder if they're understanding.
Um, I, I'm assuming, so when people say arthritis, I'm not always sure what they reference. I
Yes.
think some people, when they say general arthritis, they mean osteoarthritis, which is wear and tear. And yes, it's very different from inflammatory type arthritis.
There's another. Someone wants to know. Uh, okay, so we're not fielding questions yet about medications. Okay, so I will come back to that question that you sent privately. That's S. Erin. Someone wants to know. Vindra wants to know what exactly is rheumatic condition, example lupus, as opposed to general autoimmune condition.
So we use the terms interchangeably, right? Autoimmune basically means your immune system is not working fighting a virus, bacteria, etc. But in autoimmune conditions, auto means self. The immune system now attacks itself and its body's natural or normal cells, and that's why we have this constellation of features. Rheumatic is just a term for the specialty.
Okay, Vindra, I hope that answers your question. Someone wants to know how is Sjögren's syndrome? How is it? How serious it is, and what causes it? So the question is,
So
Dr. King.
most of the rheumatic conditions,
Yes.
yeah, most of the rheumatic conditions, we're not sure exactly what causes it. What we know is that we develop antibodies that attack normal cells. Sjogren's is it's actually one of the more common rheumatic conditions, but it's not always referred as Sjogren's. I'll tell you why. Because a lot of these symptoms are like dry eyes, dry mouth, which a lot of people pass off as normal. We look for it. It can occur by itself, or it can occur what we call secondary Sjogren's, as an overlap with other rheumatic conditions, lupus, rheumatoid, a lot of other conditions. So it's really a constellation of um, dry mouth, and then there are specific antibodies that we expect to be positive to as well, or can be positive, as well as certain features you may see in salivary gland on ultrasound, or you might see on biopsy, teardrops, salivary gland production. So there are a lot of classification criteria as I went through that we use to make to aid in classifying somebody as Sjogren's.
So a patient is now saying that I've now heard of overlap. I was diagnosed with RA since I was 26 years old. Last year, she's now 44 years old. She was diagnosed with lupus. Is this an overlap?
Well, it from what if what you're saying is indeed it is an overlap, rheumatoid and lupus, which we call lupus. It is a well-known overlap.
So she has what is called rupus, which is between rheumatoid arthritis and
This
lupus.
is based on this is based on what is the question asked. I don't know this patient to
Yeah,
say
yeah, yeah.
this is
I know.
indeed the case,
Yeah,
but
yeah.
based on what she asked, if RA and lupus occurs, it is lupus, or it is a known overlap.
I see. Okay.
It's a fairly common overlap, actually.
Okay. So there are based on our patient listing, we have so many lupus patients who for years would have been living with rheumatoid arthritis, and later on in their years, they were told that they have lupus. So is it that they would have had lupus all the time, or and the manifestations took a while to come or to be confirmed?
So that is what, like when I mentioned in the lecture, lupus in particular occurs sequentially right? Meaning, as they are making the point that it can't be one predates the other,
Okay.
right? So RA patients, and it's different. So it's I can't say I had lupus before, and then for us to make the diagnosis of lupus means it must have the manifestation.
Yes.
Does that make sense?
Yes.
Right? So it's not that you had it, but not to make the diagnosis of lupus, there are certain constitutional symptoms that you must present with. So
Yeah.
it just means that you had rheumatoid arthritis and you now
Dr. King, I think your internet is a bit unstable. You're coming across very choppy.
yeah, I don't know. I didn't realize it was mine, but yeah, I don't
Yeah,
know.
boy. Yeah, like you're all dragging and cutting in and out. Guys, we do apologize. It's it's the weather. I would imagine the weather is causing some issues with the connectivity. Someone is asking, is it necessary to take medication when flares are present? Asking for a lupus patient.
It depends. So we use the term flares very vaguely. So when somebody tells me they're flaring, I usually need to ascertain what exactly does that mean. Is it joint pain flare? Because a flare could involve any organ system,
Yes.
right? And usually if you're flaring, say for instance, if your kidney is inflamed, that's something that needs to be treated aggressively, or if the heart is inflamed. So a flare, whatever flare it may be, usually needs to be treated.
Okay. Back to my list of questions. How important is it to identify and treat each condition separately? So I take it they mean the different types of overlapping diseases.
Oh, it is very important because it's all dictated by the clinical features that is presented to you. And to get best outcome is really to ensure that you cover most systems on a clinical consultation. So you address your treatment accordingly. So it is very important because ultimately what the patient describes is the symptoms that may be emerging or present and most troublesome at a given time. And that is what dictates treatment.
Okay. Could treating one condition with a particular medication affect another negatively or positively?
It can affect that's a really excellent question. Simply because it can both more positively than negatively, or more than negatively, one may not be addressed. For instance, if
We
you
lost you
have
again.
if there is a lupus patient with primary, let's say lupus patient, rheumatoid, and you hearing me?
Yes, now hearing you. Yes.
Yeah. If say for instance, if there is a rheumatoid arthritis and lupus patient with primarily articular manifestation, say for instance, methotrexate might be great. Yeah. If, for instance, there's a lupus patient with primarily kidney involvement and joint involvement, and we're using CellCept, say for instance, to treat the kidney, the underlying kidneys, it may not necessarily do much for the arthritis. So this is what it is more. It's more than the treatment isn't necessarily based on just the diagnosis, but it depends on the predominant clinical feature at a given time.
Okay, so someone wants to know if a patient shows all symptoms of lupus and other autoimmune diseases like RA, Crohn's disease, even fibromyalgia, but the ANA test comes back negative, would you still diagnose the patient with systemic lupus erythematosus? That's the question.
It depends. It depends again to make the diagnosis of lupus is not just based on symptoms, it's also and not solely the ANE.
Say that
However,
again,
in
Dr. King.
2020,
Say that again.
I said to make the diagnosis is not You hearing me now?
Yes, I'm hearing you now. Yes.
To make the diagnosis of lupus, it's not just symptoms. It's a combination of symptoms, blood tests, and based on the physician's clinical experience as well. Yeah. In 2020, the updated classification criteria to make the diagnosis of lupus included the be positive. However, in the past, we do have patients who we deemed lupus with a negative ENA. So again, it depends on the symptoms that is presented at a given time.
Someone is saying for years they have shown all the symptoms of lupus, but their blood work is not lining up with a diagnosis. But they are showing all the signs and symptoms. What should that person do?
It depends on what exactly are the signs and symptoms, right? Um, because signs or symptoms are what people describe, and signs are what we listen or in terms of what we see objectively. Um, and it depends on your physician too as well. I'm not sure. It's hard for me to say because some people may think they have all the signs and symptoms and may not necessarily have all the signs and symptoms per se. Yeah. And that is where a lengthy discussion and clinical consultation will be most important. Yeah.
Okay. I personally would like to ask the question concerning fibromyalgia. 2 years ago, I was told I had
Mhm.
fibromyalgia. Fibromyalgia is not an autoimmune disease, is it, Dr. King?
No, it's not.
Right. It's a condition that affects the nerves in the body.
So what fibromyalgia is, it's actually not fully understood, right? It's one of the conditions that not what we assume or what we suppose is that the pain pathways are not modulated as it should, right? So certain stimulus that may some persons may not be heightened by they are heightened in patients with fibromyalgia. And so what we do know is that we have a subset of patients or quite a large group of patients who experience pain, tenderness, brain fog, can be associated with insomnia, mood changes, irritable bowel syndrome, migraines, a lot of features that fall under the umbrella of fibromyalgia, but it's not autoimmune. However, it can affect your quality of life quite significantly.
Yes, and even sometimes when I am abroad with my rheumatologist abroad, we struggle to understand. Well, I should say I struggle to understand. Is it lupus or is it fibromyalgia? Which one really kicking my butt today? You know what I mean? Because it's so similar. I can't
It
tell the
is
difference.
similar, but I do find, particularly in my rheumatoid arthritis patients, they sometimes can't tell me the difference. They tend to have a feeling which one is more predominant at a given time. It's not always easy.
No.
It's not always easy, but and sometimes I usually say try to get you have to treat both.
Do you see more and more lupus patients being given a diagnosis of fibromyalgia? Because on our end, a lot of patients are reporting back that yes.
Yeah, it's a well known associated condition. So yes, I do see a lot of patients with the diagnosis of fibromyalgia too as well.
Yes.
And it's not the easiest thing to treat, as you're probably well aware. Um, and some of the medications that we have licensed, sometimes they have side effects, availability. So it's not always the easiest to address. But yeah, a lot of our patients do um, also have fibromyalgia.
Right. I guess the journalist in me wants to ask this question because it's a question that I have been fascinated with over the last 12 years of our existence. Are you seeing more and more people being screened and tested for lupus in the last decade?
I would say yes, since when Well, I could really reference from rheumatology is a relatively grand scheme of things a new specialty, meaning and I think as a specialty grows and information becomes more available, people are more heightened and are more aware of certain conditions and what to look for. So I do notice in my clinic, you'll see the community screening more, referring patients more, with these symptoms to be to be treated.
At this point, I would do like Usain Bolt and say thank you because the work is paying off in our advocacy to get people to know the signs and symptoms. Because over the last 12 years, we've been at the helm of educating John public about the signs and symptoms and advising them if you meet three or four out of the 11 symptoms, go to your community health center, get a referral letter, and join the clinic, whether it's at Mount Hope Teaching Hospital, Port of Spain, St. James. So we have seen that because as our organization continues to hit the ground in terms of really meeting patients and what have you, we are seeing those numbers climbing every year. Every year,
Yeah,
more people
it
are
is.
being tested.
And education is very, very important.
Yes. Someone wants to, a patient is asking about, I'm having a lot of pain in my elbows when I get up on mornings. Is this escalating symptom of UCTD?
It can be. It can be.
Dr. Keisha, what is
It
UCTD?
depends on differentiated connective tissue disease.
Oh, I see. Okay. UTC means that.
Yeah.
Okay.
So it can be, depending on what your initial symptoms are, it may, if it was started off with joint pains, what say a flav or any positive, it may be evolving. It may be wise to talk to your physician and assess, make sure it's not a rheumatoid arthritis picture emerging, check inflammation levels, etc., and adjust meds accordingly. Now there are many reasons why you could have elbow pains, to be honest. For any joint that is painful, it's not just, we don't always assume, or for any area that's painful, we don't always assume it's his joint. Sometimes it could be soft tissue, tendons, etc., which can occur with rheumatic conditions too as well.
Vidra wants to know, how do you know when your symptoms have evolved into warranting an additional diagnosis and hopefully a treatment?
Well, you should have an idea in terms of, for instance, if like say for instance, if you have known to have rheumatoid arthritis and you develop rash, there are certain features that are not classic for your condition. So you will, all you would know is that you don't know your body better than yourself. Yeah? And you would know if there's been a change. What you do is make note of the change. Don't force yourself to make a diagnosis. That is what you and your physician will discuss. But focus on what symptom that you're experiencing and be in tune with your body so you can relay that. And I say that because a lot of patients come in with, I think I have this, I think I have that, right? I spend a lot of time trying to flesh out what exactly it is you're experiencing, right? And then we will try to see if that is indeed that, because there are a lot of subtle differences and nuances. So more than fighting up with if the diagnosis is changing, is to be aware and in tune with what's happening with your body.
Someone wants to know, I think Lisa. Lisa is asking, if a person has a strong ANF and ANA but negative for double strand DNA, is it considered to be lupus?
Not necessarily. Um, Meaning a strongly positive ANA simply means a strongly positive ANA. It only becomes relevant if there's associated clinical features. The double-stranded DNA, we say it's more specific for certain aspects of lupus flares, which is true. However, I've also seen patients who have significant flares with a normal double-stranded DNA. And I also am mindful in our population, our ethnic distribution, in interpreting antibodies. I think our antibodies are more common than, say, a fully Caucasian population. So a positive ANA can just be a positive ANA. It's only meant to be interpreted if there are clinical symptoms. I've seen a lot of positive ANAs without any underlying diagnosis, and it causes anxiety. So it really should not be tested um, unless there's a clinical correlation.
Okay. Someone wants to know if long-term use of Imuran can damage the kidneys.
Not usually. I mean, long-term use of anything is not ideal, but as I always say, is risk benefit. We actually use Imiran sometimes suits for lupus nephritis too as well.
Mm-hmm.
It's not my first line, but it is known to be one of the options. Say, for instance, if you're unable to tolerate the other meds to help with lupus nephritis, so it has more benefits than not.
Someone reached out to me earlier this week, talking about a whole family history of diabetes. They were told that they were pre-diabetic, but over the last month or two, their health just plummeted, where they're getting all the symptoms that mimic that of lupus. So their question would be, how does lupus and diabetes mimic each other, and should I be screened for lupus? Should that person be screened for lupus?
Yes, if they depend on the symptoms that they're experiencing, yes, it should be screened. Um, because they can't coexist. So if you suspect, because say for instance, diabetes doesn't usually cause joint pain. There are a lot of symptoms from lupus that diabetes would not cause, right? They may have some overlap, but it's not of all the conditions it's not usual that diabetes and lupus would have the. It can mimic. I mean, lupus is a great mimicker. We know that, but I would say if you suspect it or you're not sure, it is your right to bring it up to a physician to be screened accordingly.
Okay. So you would say lupus and diabetes, that's a totally different kettle of fish. They cannot be compared.
No, lupus is known to be a great mimic of other things, right?
Yes.
But to say that diabetes and like a diabetic won't necessarily have arthritis. Like for some of the common lupus features, what I'm talking about,
Yes.
need not necessarily occur with diabetes. But say, for instance, the weight loss and what we call constitutional features, not feeling well, etc., those can overlap. But some of the key defining features of lupus not necessarily overlaps with diabetes.
Okay. All right. Well, I hope that person hears. And if that person is still on, if you are showing 4 out of 11 of the symptoms of lupus, you can go to either your private doctor, ask to be referred, depending on where you are geographically in Trinidad. If you are in the East-West corridor, if you are in San Fernando or the Port of Spain area, you can go to the hospitals and ask to be joined to that clinic. It would be, Dr. King, it would be considered the rheumatology clinic, right? At Eric Williams, it's the rheumatology clinic, because
Yes,
there's no
there it
lupus
is.
clinic per se, right?
No, no.
Right. Nalisa is asking, she's asking the question about, is there something called prednisolone withdrawal? I have been on it for years and have started weaning myself out. Since then, I have been getting so much pains all over, added on to the regular pains and a lot of headaches.
Lupus. Prednisolone withdrawal is a very well-known entity. It also makes it difficult. So as I usually tell patients, your body naturally produces steroids. We need steroids. Your body naturally produces steroids from your adrenal glands. When we administer steroids, the gland responsible for producing steroids is shut off, right? And it's for this reason why you shouldn't stop steroids um, very abruptly, depending on how long. There's a nuance there, depending on how long you're on these steroids, right? On the flip side, even if you're trying to wean off of steroids, it takes some time for your gland to start to wake back up to produce the steroid that your body needs. And it's during this period that people could feel unwell and experience the steroid withdrawal features. Now, if steroids is withdrawn too quickly, there are extreme medical emergencies that can occur. So it's something that we are very mindful of.
How hard is it to get Humira and Enbrel? I hope I said that correctly. Those types of medication in Trinidad, like even like Penicillin. Penicillin is one of the first lupus approved drug. And this is like about 6 years ago. It was approved by the FDA specifically for lupus. How hard is it to get some of the new treatments here in Trinidad? Dr. King, what do I have to do? What can we do?
So, Louis, it's not just you actually in the Caribbean region. So a Humira Embrel actually is available in the public sector. The only issues we have sometimes is availability, but it is available, Embrel and Humira. We don't necessarily always use them in lupus patients. So the Embrel and Humira that is readily available, of course, if there are shortages with anything and supply becomes disrupted, but for the most part, they're available. Benlysta or Belimumab, which is licensed for, as you rightly said, it's not approved in the region, right? So this is one of the targets that we as the Caribbean Association of Rheumatology is trying to get the medication. So it's not available in the region privately or publicly. Yeah. So for drug to be approved, it needs to be regionally approved for this area. And sometimes you can infer, for instance, if it's approved in Latin America, let's see if we could get like surrogate approvals. So this is something that we're working on to get these medications available.
Okay. S. Aarons has another question. Her question is, can a stable patient with SLE and nephritis, anemia, carry a full-term pregnancy? What are the factors that can affect pregnancy when a patient has the above?
So we like patients who, if you can't carry a pregnancy to full term, yes, you can. Lupus does not affect fertility. However, there are certain things that we look out for in terms of plan to get pregnant. It will be a planned pregnancy, meaning we ideally like things to be in remission for at least 6 months, particularly lupus nephritis. And remission is requiring low dose steroids. If you manage on a medication that is compatible with pregnancy as well, we can explore the option of getting pregnant. Yeah. So it is definitely possible. Things that affect pregnancy with lupus patients would be the presence of antiphospholipid syndrome and certain antibodies that may be present that we have to screen babies for. But for all intents and purposes, this will be a joint discussion yourself, your obstetrician, and rheumatologist.
Okay. Chris has a comment. Her question is, what are the medications used to treat Sjögren's, sorry.
So Sjögren's it all depends on the clinical manifestation at a given time. If primarily dry eyes, dry mouth, I usually start off with um, hydroxychloroquine. If there's improved, some to escalate to methotrexate if there's associated joint pains. So again, more than just the diagnosis. So it's not what we just use to treat Sjögren's. It depends on what manifests at a given time. Say, for instance, I have a Sjögren's patient with interstitial lung changes, right? The medications that I would use would be different from a patient with arthritis. So this is where more than the definitive diagnosis, it depends on the clinical manifestation that is present at a given time.
Okay. Can lupus cause any
And there
type
will be
of...
two Sjögren's patients might be treated differently.
Say that again. I'm sorry, Dr. King. I cut you there.
I said two Sjögren's patients may be on two different treatments.
Just like lupus. Just like lupus.
Yes.
Yes. Okay. Can lupus cause any type of is it arrhythmia?
It that's a great question in terms of it can affect the heart in many ways. And an arrhythmia is an abnormal electrical activity throughout the heart, right? Now, sometimes abnormal electric activity, it may be an inherent disruption in the heart's normal electric activity, or if there are changes within the actual structure of the heart. Now, if you have an inflammatory process that can affect the pericardium, which is the lining of the heart, or the myocardium, which is actually body of the heart, you could well imagine that if there's resilient scar tissue, etc., that there is a possibility that arrhythmia can occur.
Okay, Akisha wants to know how common is disseminated intravascular coagulation with SLE, DIC with SLE?
So DIC is on the entity on its own, can occur in many things, and it's actually very rare. It's one of our, it's a, so what it is, for those of us who don't know, it is a medical emergency that can be precipitated by many things, sometimes infections, etc. And your body is in an extreme heightened state, using up all your clotting abilities. And so doing your body, if your body is excessively consuming all your clotting capabilities, for want of a better word, your platelets drop, etc., you're more prone to bleeding. And it's one of those bleeding conditions that's very, very difficult to get on top of and settle. So it is a very, um, it's a rare condition in itself, rare in lupus too as well, and it's a medical emergency or catastrophe.
Wow, wow, that sounds scary. Chantal wants to know lupus migraines. How is it diagnosed and treated? Chantal has been struggling with
So
headaches for
lupus,
years. For years, since I've known her for 12 years, headaches has been her. Ooh, it's really bad.
so the migraines. So when we look at lupus, as you know, it's an autoimmune condition affecting inflammation. Now there are different symptoms like, say for instance, migraine, seizures, etc., that can occur, can affect the nervous system, and we reference it as a broad term neuropsychiatric, and it can range from migraines to mood disorders to um, severe inflammation of the brain, causing what we call um, in, vasculitis, cerebritis, etc. I say that because depending on what is present at a given time will determine if you need to use immune suppression, if it's inflammation, or for instance, migraines or some of the mood disturbance. You treat like how you would treat regular migraines or mood disorders. Yeah. And is usually overseen by the neurologist.
Okay. Dr. King, this is a question that I think a lot of patients have all come together to share over the years, that doctors don't listen. Not saying you, but doctors in general
Uh-huh.
don't listen. How can patients practically navigate through their clinic appointments, their doctor's visits, by getting doctors to listen? Because there are cases where I know even in Tobago, and I know Chantal would not mind if I mention this. Chantal has been accused of being hypochondriac, faking just to get pain meds. She's been dismissed by nursing staff, dismissed by doctors. I don't want to cast any blame or anything like that, but it's a common complaint we've had over the years where patients they're expressing concern that when they go to their appointments, the doctors are not listening to them. What would be your practical advice? I mean, you are well respected. I mean, you're my doctor. I've never had a bad incident to say that you never listened to me, but there have been cases where a doctor is very dismissive and they don't even ask how you're doing. They just start writing a prescription without listening to your concerns or trying to really calm you, because many patients show up at an appointment, whether it's 6 months, 3 months, 8 months, a year. They have a book and they are panicking and there's a lot of anxiety because things are going wrong in their body, but there's nobody to listen to them, make them feel like it's all in their head, dismissive. What would be your practical advice and to help allay some of the anxiety a lot of our patients are suffering from?
Well, I think it's probably the evolution between doctor-patient interaction, where in the past, I think it was more doctor-centric and the doctor is talking down to you and you following. I think what I would advise patients is to be aware of exactly what's happening to you. Yeah, you can log your symptoms, etc. It is also your right to ensure that the doctor listens to your symptoms. If you feel as if you're not being heard, you could also ask to be escalated to a more senior physician too as well. It is your right. And I think some people don't understand, or I've also noticed that some people feel uncomfortable or unaware that it is your right to get something from a consultation. Yeah, not just, it is your right to, and understanding that can feel important, because I can understand it can somewhat be an intimidating interaction, right? And you're overwhelmed. You may not always be um uh, you may not always be equipped to articulate what's happening. But simple things like, I have patients who ask me, they want to know what their blood results are. They know what it was from before. And sometimes even be an active participant, and they'd be like, okay, I want to take a picture of my labs. I want to share this with this doctor, etc. So, and I welcome that, because it is your right. It is, and it's yours. So I think is also trying to understand your role in the consultation is not, I mean, I understand it's intimidating, but I understand that you need to get something from the consultation too as well. And also being aware of what's happening to you too as well. There are a lot of people who are not aware of what's happening and not aware of the medication, and they also abdicate responsibility to the physician too as well. Yeah. So it's also meaning that you're waiting for it's supposed to be a joint interaction, and primarily patient centered, and meaning you're supposed to get something from the interaction. Yeah. But you need to also be equipped in terms of knowing what's happening, to know your medications, why you didn't take your medication. Also not being fearful of um because some patients will tell me, oh, I didn't get my medications and I don't want you to buff me. And I was like, why would I be buffing you? This is not, it's not a parent and child interaction, whatever. Yeah, if you understand what I mean, right? So it's understanding your voice in that conversation too as well.
Would you say that the onus is on the patient to ensure that they are taking their notes and bringing it? Because, we struggle with brain fog, we struggle with anxiety. You sit down in the doctor's office and your mind goes blank. I am sure a lot of patients, they have a ton of questions, but the minute they reach in front of you or they reach in front of the doctor, their mind goes blank. So the onus is really on patients to take note and say, okay, doc, I
I
have
would,
this
well,
question.
yeah, because the doctor wouldn't know exactly what's happening. So we would have these symptoms that we look for, but ultimately the person who knows what's happening to you the most is you.
You exactly.
So for you to get the best of a clinical consultation, you need to be aware of the information that you bring into the consultation and what you're getting. And actually, I must say that has improved. I find with time, because our patients who are now very direct in terms of, as I said, they want to know this, they want to know, and it's good to be But on the flip side, sometimes we have patients who sit there and they don't know what medications they're on. They wait. If you understand what I mean.
Yeah,
So it's meant to be an interaction where you know what you're getting from your consultation.
exactly, exactly. Vintra wants to know, how can someone get a referral to the hospital clinic? I guess it would be your clinic if a person's private doctor doesn't want to refer and the health center in a Wranglers doesn't want to register or accept the patient.
That's an odd scenario because
Yeah,
yeah, I don't know how to comment on that. So I suspect this coming more from the history I've been missing, which probably this is not the forum to highlight. So yeah, if you want to get the information, I could probably look into it after. But anybody could refer to the clinic. You can go to a health center and they refer that. It's not a But the health centers usually screen depending on what the symptoms are. It's not just because on the flip side, it's a tertiary. It's not meant to be bombarded with just a screening facility. It's meant to be screened in the health center and referred accordingly once you suspect. Yeah.
okay. Um, Someone is asking, Candice John is asking, what causes facial pain in a lupus nephritis patient?
That's I'll have to get more. That's a very vague
Vague.
symptom
Yes,
in
okay.
terms of. where exactly on the face, if it's a jaw, say for instance, if you have arthritis, if you've been on steroids, a lot of things that could contribute to so that would need to be discussed a bit more.
S. Erin is just lamenting appointments as a headache recently. As the onset of COVID, doctors and clinics have spaced out what they deem to be stable patients, and sometimes phone calls are not enough. The person is just making a comment, it's not a question. Can lupus cause UTI to happen often? That's interesting. We got 4 calls this week about urinary tract infections, and the person's were on steroids. I'm just wondering if there was a link with the steroids.
Exactly. So it's not necessarily that lupus may cause, but the medications that you're on is quite in your immune system, right? And steroids is known to cause lupus. So if your immune system is not if you're on medications that are meant to be quiet in the immune system, underlying condition, I take it well imagine is somewhat more susceptible for infections, and urinary tract infections are usually quite common.
Um, a patient is lamenting that for someone like me who wants to find out if dosages can be tapered off in CELSAP, but they all send us back to a rheumatology clinic, but we have these very spaced out appointments. Any solutions to this? So the person wants to
I'm not
taper.
sure what
The person,
exactly
yeah,
is
they're
it.
asking if they can taper off on their salsa, but every time they ask, I suppose they're being told you have to go to their clinic. So probably nephrology is saying you have to
But
go to rheumatology. I'm not sure. The person wasn't clear.
it that's difficult to explain simply because it depends on the indication for CELSEP. If your indication is for kidney clinic or kidney, um, if the indication is for kidney for nephrology reasons, then I would imagine the nephrologist could tape it. If it's for say cerebritis or skin or whatever, it depends on the manifestation that's being treated. So it's not simply just tapering and
Okay. This is the mother of a lupus patient. She's a child. She's asking the mother, can a doctor perform surgery on a lupus patient who is experiencing calcified ligaments or hamstrings, or is there any medication to control this type of condition?
it depends on what the condition is. Um,
Dr.
um,
King, I would like for
that
the
yeah.
patient.
You see, I'm a little mindful of clinical consultations in this
Yes,
setting
yes,
because it's not the forum for such, especially when
yes,
you need to gather more information.
yes.
Yeah.
Yes. So Listra, you heard Dr. King, all right? So she's unable to, to specifically address this question. Um, okay, so going back to the question about lupus nephritis with the facial pains, the person is saying the facial pains resonated from the jaw and the cheeks, along with headaches and sometimes on both sides of the face.
Right. So based on the location, I mean, it could be areas with the TMJ if you're on steroids, etc. As I say, this will need to be teased out in a clinical consultation.
Yes.
So I
All right.
can't give a diagnosis
Yes.
in this setting. Yeah.
Respected, yes, of course. Someone wants to say, my lupus patient is 11 years old. Is it advisable for her to take the COVID-19 vaccination?
Yes, we are advising patients once they're within the subgroup, um the vaccinated age to take the vaccine.
Right.
Yeah, but I mean, you could discuss. There are a lot of other things to discuss in terms of how active lupus is, etc. Yeah, and if you need to suspend medications and those bits.
Going back to the onslaught of this whole session, why are lupus patients more susceptible to get more than one autoimmune disease?
Well, it's the nature of the I don't know how to answer that. Most patients would have a myriad all of antibodies, right? And it depends on how you look at it. You can look at it. So it yes, it is different systems for different conditions, but ultimately it's inflammation affecting our organ system, right? And if you think about it like that and you approach the treatment, that's why sometimes the definitive diagnosis is not, it helps in terms of knowing what you have, forming community, etc. But, and prognosis, but it ultimately is an inflammatory process that is affecting healthy tissue. Yeah. And as you can imagine, if that is left to rampant, it could affect any system. Yeah. And
Okay.
each diagnosis is a description of an inflammatory process affecting particular conditions. Yeah. I don't know if that makes sense. Yeah.
Yeah. So, someone wants to know what can be done either by doctor or patient, or even both, to minimize the effects of these overlapping conditions. That's the question. What can be done by
I
either
don't think you could
doctor?
do anything per se to minimize the occurrence. What you can do is try to treat as best as possible. And truthfully, one medication that you may use for one may most likely probably treat both, or whatever you choose would be something that is directed, to treat both.
Approximately how long, when you have just been diagnosed with SLE, does it take to get it under control?
Ooh, that's an excellent question. It all depends on how aggressive the condition is initially. Um, and like we know, for instance, young females tend to be quite aggressive. Um, pediatric populations tend to be more aggressive than adults. Um, and sometimes men who get it, although they get it rarely, they tend to be more aggressive. So it's not necessarily, and it depends on what you present with initially. Some people may present with, um, say, joint pains and rash versus somebody who presented with a pericardial effusion, which is collection of fluid around the heart, or kidney involvement. It depends. A lot of things dictate um, how aggressive things could be. So it's not the easiest question to determine. But what we do know is in our ethnic distribution and Black patients tend to be way more aggressive than Caucasian patients.
Right. How important is diet when managing lupus?
Well, that's a great question. So I know there's been a lot of chat about inflammatory diets and um, turmeric, and as I say, we don't have or there's not a lupus diet. This is just my personal take. So this is not medical advice. It's just my take on it. I
Yes.
think we should unprocess our diet as much as possible. And that goes for everybody, be it autoimmune conditions or not. And then there's also in your body in terms of certain that will trigger you respectively. And from all the patients that I've seen, there's particular things that some patients may say tomatoes, some patients may say malnutrition. I also know in your body to see what triggers things too as well. Yeah.
Okay. Someone, someone wants to know if they can go on a juice diet and they would be cured because they're seeing so many YouTube videos of people touting that they have gone on just strictly juice fast smoothies and they have been cured. Should I attempt to do this?
I That would be entirely up to you. It's not standard practice. It's not something that it's part of our guidelines, so that would be entirely patient dependent.
Right. And someone is now sending a message here about they've been doing research on strictly eating a carnivore diet, just meat, just meat, just meat, just meat. So
Yeah, there's a lot. As I say, there are a lot of things out there.
there's a lot of
Yeah,
things out there, but I say the onus is on the patient. If they try it and it's working for them, stay with it, right?
exactly. And remember, no two people are the same, just as no two conditions are the same. And that is actually where even treatment, we try to treat things in a with some assumption that certain things I believe in time with research, etc., we'll get a better understanding of patients' individual genetics and tailoring medications for individuals. And it's with that same vein, I would interpret what you do with foods and even how you respond to medication. We, as much as we try, no two persons are the same. So you can imagine that certain things would react to people differently.
Right. This is a question that a lot of patients have been talking about lupus and cancer. Someone is saying that they were told that their cancer markers were high and that lupus would have probably been responsible for that. Are high cancer markers commonly associated with lupus, and what should I do?
I'm not sure what they mean in terms of now sometimes when we search for this is not just for lupus. Certain conditions they have what we call cross reactivity in terms of positive blood tests, where sometimes it may come up positive um, because some other antibodies positive. So I'm not sure if that is the question, because tumor markers being elevated doesn't necessarily mean that you have the tumors. So I don't know. Um, yeah, so I'm not sure exactly if that answers the question.
I would ask the patient, and if you would like to, ask the question for yourself, just to be clear, you can do so. But before you do that, there is one patient who's asking about, Dr. King, can you recommend which vaccine should I take is solid and safe for a lupus patient like myself? The person is still, I remember we did a session since last year talking about, yes, patients can take the vaccine, but this person wants to know your specific recommendation.
On my specific recommendations, I actually don't have any particular preference for vaccines. I would say, now I know there was the issue with the clotting with AstraZeneca. So if, say, for instance, you have clots in the past, I might probably avoid that and probably try Pfizer. So that would be the small nuance to the answer to the question. But for all intents and purposes, we haven't really highlighted a specific um, vaccine for specific conditions, if that makes sense.
The same patient with the child who has lupus, and you said you aren't able to provide any type of um, medical consultation here on this forum. She's just asking again which doctor to go see to treat with the calcified
So
hamstring
if
for her daughter.
if it's calcified hamstring, I'm assuming orthopedics might be the best person. That is what I would suggest. If it is indeed calcified hamstrings, yeah.
Okay, so you would suggest that she goes to orthopedic, right? All right.
Yeah.
Okay. Um, a patient is saying my rheumatologist added adult onset still disease to my previous diagnosis of SLE and Sjögren's syndrome after being hospitalized with several days of fever, 105 degrees Fahrenheit, Solmedrol 1000 mg pulse over 3 days reduced my fevers. How common is this?
Adult onset still is actually not that common, but it is a condition that we look out for in adult patients. There's a pediatric equivalent as well, what we reference as systemic GIA, which I've encountered before. But it's usually high-grade fevers with associated rash. It's a clinical entity on its own. Sometimes the ferritin levels can be very high. So it's something we consider for what we call unremitting fever. It usually settles nicely with steroid.
Okay. The person is asking again, excuse me. I'm not even going to ask because you dealt with this before. How close are scientists to finding a cure? I mean, we saw they were saying that they found a cure for cancer, potential cure. How, what's the progression of scientists and studies and research to finding a cure for lupus? And is anything being done in research with regard to bringing us closer to a cure? I think everybody wants that. We're tired of living in pain.
Yeah, I think everybody wants that. Yeah, I cannot answer that in terms of where I know a lot of within the last few years we have had so Ben Lisa was a few years licensed within, let's say within the last 5 years, at least 3 medications have been licensed for treatment of lupus, right? The voclosporin, anfolamab, and Benlysta, yeah. So a lot of research is being done into lupus treatment. I imagine within this, they try, because it's such a, if you look at the pathophysiology or the physiology of lupus, it's the immune system is a very, very complex system, right? And even medications that we use target different pathways. So what we know is within the last few years, have been trying to modulate and treat and modify these different pathways as much as we can, because Benlysta pathway is different to voclosporin, which is different than anfolamab. So there's been a lot of work, but I'm not sure how far, when a cure will be on the horizon, but I know a lot of work is being done.
Yes. Someone wants to know, it's a personal question. The question is, um, how can someone with lupus date Dr. King? You know, because you're a medical doctor, it's not easy to live with a disease that is potentially wreaking havoc in your body 24/7. As a medical doctor and as a woman like myself, how would you go about advising me to get into the game of dating? That's a really,
Well,
that's a real
that's a
hard
first.
question, eh? It's a real hard
Um,
question.
it's a difficult question, even for people without lupus, right? In terms of well, how I look at things. Now, this is not, of course, it's not a clinical question. This is just how I look at things, right? Everyone, I mean, dating itself is difficult, right? Um, Everybody will have something that they're dealing with. I know lupus affects um your life quite substantially, quality of life and um your quality of life and I guess certain aspects of your self-image, etc. But everybody, you never know, everybody is dealing with something. I would say when you're dating, to be upfront and transparent as you are. And I mean, we have a lot of success stories with people successfully dating lupus patients. So a lot of it too, I think how you view it would also affect how the other person views it. So you could choose to look at it. I would say understand that you're an individual with lupus versus lupus as you're identifying identifying trait. I don't know if that makes sense. Yeah.
Lupus
So
doesn't
although you have
define you.
lupus, it's still a person. Huh?
Lupus doesn't define you.
Exactly. So you're a person worthy of love, worthy of dating with lupus.
Well, thank you, Dr. King.
Yeah.
That's the first time I ever heard with all the webinars. Nobody was ever so upfront about that, because, and I think patients struggle.
It's a valid question, though. It is a
Really
valid
valid.
question.
Yeah, I
And
mean,
it is a fear, but it's also a fear. I'm not taking away from people. It's not a unique fear to lupus. It's a unique fear to a lot. It's a unique fear and concern to a lot of people. Hello?
yes, I'm here. Yes,
Yeah.
the patient said, thanks for being so honest because it's a question they have asked their doctor, but was never given a response like what you did. So the person is saying, thank you very much. Um, there is someone here who has been showing all the signs, all the symptoms, but there's no history of, autoimmune conditions and stuff in their family tree. But they want to know if lupus is hereditary. Can you talk about the genetic factor, the genetic link with autoimmune
So
diseases like
we
lupus?
know it can run in families, and when we look at her in terms of genetic susceptibility in any condition, the closest reference you would have is what we call monozygotic twins, right? And if I'm not mistaken, the chances of it in twins is probably like 15%. So it does run in family, but a lot of my patients that I've see, you still hearing me?
Yes, hearing you fine.
Yeah. A lot of my patients that I see don't have a family history of lupus. Yeah. So it's not fully understood. And when things medicine, we say it's multifactorial, a bit of genetics, environment, and possible infection of virus in the past. But basically, it's not fully understood.
It's not fully
But it
understood.
can run in the family.
Okay.
And there are some genes that run that they can't check for that can run in families. Yeah.
What are some of the genes? If we can get scientific here, what are the genes?
Like Pete is very, very common. It's not just the antibodies, and it's not absolute either. But the like PTPN2, it's a lot of different fits into the genetics of it. Yeah.
Okay. Is treatment for all connective tissue diseases similar or symptoms guided only? Let me read that question again. I didn't understand the question. Is treatment for all connective tissue diseases similar or symptoms guided only?
So the easy answer, I guess, would say symptom guided. So it depends on. So if, for instance, I have a patient with lupus who is in remission, his diagnosis is still lupus, but you may not. Let's say you're not on any medication, you're not requiring steroid. I would not put you on steroids or hydroxychloroquine or Celiac just because you have lupus, if that makes sense. So it's primarily dependent on what symptoms.
Okay. A patient said, sorry to be vague, but can a patient with a past history of discoid lupus and a lot of scarring, doc, what can I use topically to prevent, to reduce the discoloration or to tone it out? Or can we move forward and do tattooing or, other procedures that could even out the tones of my skin?
I don't want to answer too much on that because that's primarily dermatology. And I would say have a conversation with a dermatologist. Now, I know there are a lot of topical treatments that they're expanding for discoid lupus, but I'm not sure where it works in terms of I'm not sure in terms of where it works for scars, old scars. Yeah.
Okay. How do we know when we should go to the emergency room? A patient wants to know this. How do we know when to go to the emergency room?
Well, I would say if you have like a severe chest pain, severe headaches, severe shortness of breath, a symptom that is troubling at home on emergency, just like anybody else, you go to the emergency department.
The patient is saying, from
Or
my
severe.
experience, when I get there, you are treated like by now, and you should. Uh, Doctors are telling them, well, you should know how to manage your flare, but it's unbearable, and you never know if it's a flare or it's something else. So the person wants to know: is it a flare I'm going through? To decipher, is it a flare I'm going through, or oh my God, is it something new with lupus that I need to go to the emergency room? That makes
You
sense.
go to emergency room and have that assessed. It's not easy to say if a flare is happening at home. If I see in clinic too, which I've done,
Yes.
and the symptoms are, and you need to get blood tests done, etc., I'll send it to the emergency room. Yeah.
Last question. Is it okay to take estrogen after a complete hysterectomy at the age of 56?
It depends. That'll be a conversation for a gynecologist in terms of what symptoms that and depend on the hysterectomy if they remove your ovaries. If is it, I imagine it's a lupus patient taking estrogen, yeah?
Yes.
I guess I want to know in terms of taking hormones. Now that would be, it's a very good question. You'll have to discuss based on this is where the previous like antiphospholipid syndrome, that nuance conversation will need to be, so that would have to be discussed. Yeah.
Okay. We have a lupus patient, actually a male. He's asking, is it possible to test those genes you were talking about, for instance, in your children before the symptoms are manifested?
No, I would never advise that.
Okay.
And also I would never advise even doing an ANA because it causes undue anxiety, right? But because let's say the ANA comes back positive or the gene comes back positive, what do you do next? Are you living in constant fear and putting anxiety on a child and something may never happen? And even if something is to happen, it's only meant to happen at that time when symptoms emerge any which ways. Yeah?
We have a patient. I know she doesn't want to be named, but we hear a lot about lupus nephritis, lupus affecting the heart. I've not heard very much about lupus affecting the lungs. What are some of the early signs? Sorry?
It's very common, lupus affecting the lungs. So when you look at the lungs,
I
lungs can be affected in.
sorry, I was going to say on our database based on that, I've never heard patients coming forward to talk about lungs. Mostly it's kidneys and heart.
Right. Lung is probably more common than heart. So your kidneys, your lungs, sorry, can be affected. If you look at your lung, there is the lining of the lung, which is the pleura, and quite common is pleurisy or pleuritic type pain, which is inflammation of the lining. Then they have the body of the lungs, which is sometimes you have interstitial lung disease, which is like, let's for the analogy, the meat of the lungs, and they have the blood vessels, and the blood vessels can be affected in, they can become inflamed, they can become stiff, they can be clots, so it can be affected in, yeah.
In terms of things like cystic fibrosis and stuff like that, like how do you catch those things before it wreaks havoc, like progresses? Are there any telltales like of how, okay, so how you're getting chest pain, shortness of breath? A lot of lupus patients who had COVID like myself, up to this day it's been 2 years plus, I still am having a lot of short breath issues. I'm still having, like, I cough a lot, I still have to use my inhaler, I have asthma. How can you tell if it's, you know, progressing, that I need to come to see you and say, okay, doc, could you refer me to pulmonology, or should I, what do I need to do? How can we be proactive for issues of the lungs? What are
All
the
right, so if your symptoms are very, if it's bad enough, you go to emergency department, we're admitted and they assess you there. If not, at your consultation, well, it depends on the arrangement that you have. Depend on some of my patients, I give the option to come in if there's something that we can't troubleshoot in clinic, so we can see what can be done. Like say, for instance, if a referral needs to be made, etc. But if it's really bad, you go to emergency department, and if it needs to be escalated in terms of getting CT scans and stuff expeditiously, or if not, you at the next consultation explain to the doctor experiencing shortness of breath and most likely order a CT scan, refer to chest for lung function tests, etc.
Okay. Someone wants to know, what does it mean long term having SLE, lupus, and ILD?
Right. So interstitial lung disease is when an inflammatory process affects the lungs, right? And that is the meat of the lungs, not necessarily the lining, but the meat of the lungs. It depends on the state at which you catch it. I have quite a few patients like that. It has a better when ILD is associated with an autoimmune condition, it has a better prognosis than if it's not, or what we call idiopathic. Yeah. So once your physician is in tune, escalate treatment accordingly, and we have a lot of treatment options now for conditions like these.
So if how, you know, having SLE, how would you know if your lungs are affected? Obviously, the telltale signs would be you're struggling to breathe, can't walk up a flight of stairs, you're probably gasping for air, coughing a lot. Are those some of the basic telltales?
Yes, yes,
Yes.
yes.
Okay.
Respiratory
Patient.
symptoms, yeah.
Right, a patient wanted to know. Dr. King, just for recording purposes, I just wanted to get your professional opinion on lupus in Trinidad and Tobago and how progressive it is in terms of more and more. I know you were just quoted as saying, yes, you're seeing an increase in the number of persons being tested for lupus. What do you think of the work that Voice of Lupus is doing, and how can we better equip ourselves to do more? What are, you know, sitting in the medical community from that perspective? What are your closing remarks?
From what I gather, I think Voice of Lupus is doing a lot to raise awareness, and also providing a forum for patients to, like this, to view their concerns and I guess empowering patients. I think you're doing a great job. Um, More than my take, I think sometimes where we see the gap, and even as the president of the Caribbean Association of Rheumatology, some of our goals is kind of bridging. So I would have my views as a physician, and I think the gap is bridging between um, physician and patient, right? So being an advocate for the voice and things that we like in studies we realize that some of the gaps that we have, say for instance maybe fatigue, or say for instance you may realize that a lot of patients are asking about diet, right? And there are certain areas, so I guess being patients advocate for things that sometimes doctors may not be equipped with, right? Say for instance I'm not a dietitian, but I think it's bridging or finding, getting that information that is very patient centric, and then trying to bridge that gap between physician and patient. I don't know if that makes sense. Yeah.
I think that is a great theme in going forward, that we need to hold each
Yeah.
other's hand in managing
Yes.
patients and their symptoms and the disease itself. It takes a collaborative effort, and I remember when Dr. Lynch had done his webinar on lupus nephritis. He had talked about, you and him had discussed, there needs to be that multidisciplinary approach. Every specialist need to be working together to help a patient, and it's very hard. I mean, I know you try your very best at Eric Williams Medical Sciences Complex, but there are a lot of issues that patients come to us, and I don't consider myself equipped to really give the advice. How do you navigate through some of those challenges, especially with doctors? Would you consider lupus an invisible disability, Dr. King? This has been my campaign this year. Lupus is an invisible disability. What are your takes on lupus being a disability?
Well, it is a condition, it is a disability. But how do you define disability in terms of what is your definition, or what is your take on a disability?
Well, most disabilities don't necessarily have to be physically seen. A lot of people
Agreed.
have the mindset that the only way that a person is recognized as disabled is if they are on a wheelchair, if they are blind, they are deaf or mute, or if you can physically see their ailment.
Yeah, well, that wouldn't be my take. And I don't think, um, I guess the gap may be in terms of people relaying that to their social support systems. A lot of patients, from what my, because I would be aware, I'm fully aware of all the complications. So, I mean, being a physician, most patients who come to me, have some sort of disability, right? But I think the gap is in social interactions, and sometimes I see some patients find it difficult to even convey to their family members that they may be looking good but they're not feeling well, etc. And I guess all of that is in terms of education. Yeah. Education in terms of um, public education. Yeah.
So just to be clear, do you consider lupus one of those disabilities you cannot see?
If you if you if you describe it in terms of I you see, I don't see disability like how you would see disability.
Tell me how you
Yeah.
see it. Tell me how you see it.
Uh,
Tell me how you
Disability is
see it.
anything that disability for me is anything that takes away from your usual day-to-day functioning. So it could be mental, it could be physical, it could be, right? So a physical disability for me, it's not necessarily like will have to be like just amputee or mute, not that. A physical disability for me is somebody who's not well. So a heart failure patient. If you understand what I mean. So for me, disability is majority of the patients who are not well. Yeah. It doesn't mean that everybody's unable to work. I'm not saying that, but
Yes.
it means that everybody who's here has a, you know, has something that they diagnosed with. So that's how I see disability. I don't see it as, oh, you. I mean, it's just very different from a physician
Perspective.
standpoint. Yeah.
Yes, yes, because there are a lot of patients who physically look well. I mean, I thank God for the power of makeup and filters that I can look a particular way. But if I were to strip of all of that, I still don't always look ill. And it's a struggle, but I mean, it's a dialogue that I continue to have with patients because they struggle with the acceptance or to validate that they're sick because they don't look a particular way for illness to say that, hey boy, that person are looking sick, or you can see that person. So it's like bridging the gap. And how do you help patients to, or empower them to speak up and be their own advocates, and also even within the medical community, because patients are complaining always that in a particular under the SWRH, a particular doctor is refusing to sign off on assistance for patients who are really struggling, and I don't want to get involved in politics. I don't want to be bad mouthing anyone, but there is a legitimate concern where patients have been coming to the Lupus Learning Resource Center in tears saying, I can't get any help. Social welfare, the doctor is refusing to sign off on social welfare documents. And the doctor is telling me, I haven't lost a limb, so I'm not disabled. So that's why
Oh yeah, that's difficult for me to answer because as hearsay, I'm not saying it
of
doesn't
course,
happen, but that's not
yes,
outside of my jurisdiction, so I can't
yes.
comment on
Yes,
that.
I know you can't, but it's really just to get from your perspective as someone who's working in that profession, in sitting, because you see hundreds of patients with autoimmune
So we
disease.
provide disability if we deem patient is disabled, and there are many factors that will contribute to
Yes.
getting disability, and we do it all the time.
Yes, a patient is asking, the difference is that when you have a disability, it's constant. However, lupus symptoms come and go. Is that a way, that's how doctors are able to differentiate whether that person, warrants to get the document
So
signed?
having a disability means, so if it, that's why I say what you define as disability. If you're having a condition, right? If
Yeah.
you have something that can go into remission, you're not permanently disabled. Yeah, meaning you're not permanently disabled from working.
Yes.
And I caution patients in trying to get permanently disabled from working. It doesn't mean you don't have a disability, but being permanently disabled from working
Yes.
because it affects your quality of life as well too, right?
Yes. Of course.
Um, Meaning not working too as well, and then some patients you may be going through a bad, so we can assess, right? Um, and if we are able to attain remission, then you're not permanently disabled. And the form is such that they ask if this is a permanent disability. So what I usually do is give a set period. Um, what I do is give a set period for reassessment, and that hasn't been really a problem.
Yes, yes. A lupus patient is asking you to explain, because I think this is what happened to them. They were given permanent partial disability. What does that mean? They don't know what it means.
I don't know. I don't know what that means either.
Right.
In
Sorry.
terms of, I don't know if it's a percent that they gave on the form, or I'm not sure if it's a technical term they use. I'm not sure what
Okay.
that means.
And I promise you, this is the last question, Dr. King. This person wants to
Yeah.
know, what are the factors to be declared disabled?
So it depends on. So for instance, if I have a patient who, well, I have end organ damage, right? And end organ damage may not necessarily be a physical thing, and then you have quality of life disturbance, right? For which you may need some time to assess treatment, etc., and then reassess. So if you fall into any of those categories, you may get um, an assist. You may get certain percent disability to be reassessed in a certain period of time. If it's end organ damage and you don't expect any reversal, then it's permanent, if that makes sense. Yeah.
Okay. Well, Dr. King, I cannot thank you enough. It's been 2 hours that you spent here with us. Thank you so much
Yes, it
for the
was. Yeah.
time. Yes, thank you so much for the time, and thank you for
You're
going through all
welcome.
the questions that a lot of our patients really wanted to get off their chest, because it's very difficult to have these one-on-ones sometimes in the public health sector, and it's really it has added enough value. I wish I could share the screen to show you the tons of messages I am just getting in my inbox that, thank you again for, just committing to spending this time with us. A lot of patients have been saying that, they want to come see you privately, how to do that, how to get access to you. Feel free, you can share your office lines. I know you recently moved south in Gasperlo, right? Your office is in
Yes.
Gasperlo?
Yeah, but I mean, I work primarily out of Eric Williams too, as well, and
Yes.
my clinic times actually are not that bad. Yeah.
Right, and for persons who don't know how to, you just go to your health center, you can go to your doctor, your private doctor, and you can get a referral letter to join the rheumatology clinic at the Eric Williams Medical Sciences Complex, and Dr. Keisha Davis King will be happy to see you there.
Yes.
And again, I want to say thank you. So if there are no
Yes.
more questions, there are no more questions. We're closing it up. That's it.
You're
That's it.
welcome.
The king needs to go and stretch and have a nice meal and relax. She's been on her feet all day. So again, thank you, thank you, thank you. So wishing
You're
you a wonderful
welcome.
evening, Dr. King. Wishing you a wonderful night. Thank you again.
Take care.
Okay. So patients
You
don't
too. Bye. Good night, everyone.
Bye, bye, bye.
Bye.
Patients, don't leave. I just want to chat with you a little bit concerning some of the activities the organization is planning. So many of you, oh gosh, you all are so rude. Some of you all you're leaving, boy. What is wrong with all you? Eh? A little love for me, now, man. A little love now. Dr. King did an awesome job, and that's value. That's value that I could not even pay for. And really, really, really thank Dr. King again for spending these last 2 hours with us. I would like to just ask lupus patients, those of you who are still on, 47 of you from 60, I would like you to just participate in our little poll. Hang on a second. Let me just get the poll going. We would love to have some feedback from you with regards to this webinar, and um, what would be your topic of choice if we had to invite another doctor? What would be your topic of choice in terms of oh, hang on a second. In terms of having another webinar? Unfortunately, I can't get the poll going. Let's see. All right, it's unfortunately not working. So you can let me know, for those of you who are on our patient support group on Facebook and on WhatsApp, send me some suggestions. It would be nice to hear from you. The Voice of Lupus Foundation's Lupus Learning Resource Center has somewhat, we're near completion, so we are just right now we are looking for volunteers. So for those of you who have administrative office administrative qualifications, we're looking for an admin to volunteer their time at the center. It would be twice a week. Please let us know if you can facilitate. We are also looking for someone to assist with our social media, as well as, and when I say our social media, we have someone who volunteered, but we would like another person to work with them. It's been very daunting managing this organization by myself. And it has come a time where I can no longer do it all alone, because the organization is growing tremendously, and the needs of the organization has been growing. So if you can volunteer, if you can commit to volunteering, we are planning a barbecue fundraiser. We would like, this is to facilitate the programs that we have set up for the center, where we are going to have testing done. We're going to be providing eye testing, we're going to be providing dental testing, we're going to be providing counseling services, and it would be done via appointments. And we are asking persons to help with this barbecue fundraiser because we have to purchase medical supplies for the doctors and what have you. So we are just, just mentioning that we will be having this barbecue in the month of July, and we would appreciate all hands on board to plan and to help to help sell tickets so that this can be successful, so that all the activities that we have carded for the Voice of Lupus Foundation's Lupus Learning Resource Center can go on and can start finally. We have two doctors who have committed to volunteering their time, and when I say volunteer their time at a reduced cost. So it is going to be a paid service that the organization will have to fork out, and we would need your help in making sure that patients who can't afford to do so would not be deprived of that, so we'll keep you posted via the WhatsApp support group as well as on Facebook. I'm sorry, I've been trying to launch the poll, but it's telling me that I am logged onto a device, but I am on the device and it's saying that it's inactive. So I don't know what is that. I don't know anybody would be able to assist. I do apologize. I don't know what happened. I know I had launched the polling session before. Can anybody offer some technical advice here? I don't know what might be happening here on my settings. Does anyone know? I mean, you can unmute your mic and speak. I'm not sure. I'm really not sure how to do this. Oh my goodness, Wendy, are you here? I am so sorry, I did not see this question. I am so sorry, I didn't see this question. This was a really good question.
Yeah, hi, that's okay. Next time.
I did not see that question. Your question was, why are doctors in the rheumatology clinic that are not rheumatologists? I guess maybe that based on their training, they have to volunteer some of their time or be to make up points. I don't know. We do have a medical doctor studying right now. Maybe he can chime in. I don't know. I'm so sorry. I'm so sorry. You could have unmute your mic and say something.
No, realized the time was running out anyway. So
yeah, and I didn't want to keep her. I didn't want to keep her too long. She had a long day, and
yes, I agree as well.
Yeah. Hey, Marian Brasny. Hello, managing alopecia. Yeah, all of these things. Oh yeah, right. So that's a topic that we can probably work on. Wendy, what would be your suggestion? I mean, I'm trying to gauge from everyone here. Some practical topics that we can, try to see if we can get these webinars going in terms of topics and content to help patients, with various concerns and to raise awareness as well. I want to write that down before I forget, having a lupus brain. I will forget. Just wanted to refer to our lupus. We have a lupus, a specific plan that we give out at the center that helps you to prepare for your appointments. So it's called the lupus care plan. So for those of you who would like it, you can message me and I can send you a PDF version and you can print it and you can use this repeatedly when you go to your clinic, because sometimes I know you have a lot on your mind and by the time you reach by the doctor, your mind goes blank. I don't know if it happens to you, but it happens to me. You go there, you have so much questions and you just forget. Invest in the little notebooks and take your notes while you're sitting and waiting. Take your notes, that you can ask, so you can refer to your notes, right? So managing alopecia, is that how you pronounce it? ALOPECIA. What other topics? I really would like this forum to just help me in coming up with some content so we can continue the webinar. Because the webinar,
I think another topic could be on nutrition.
So lupus and
because
diet?
Yes, because Dr. King would have mentioned the treatment, and in between she
So
would have
Sunday.
mentioned the turmeric and so forth. But I think that area is a really important area.
Yeah,
And it's not just focusing on the pills.
but here's the thing. Sunday we had a holistic health and wellness holistic health and fitness expert Setwayo Laborde. He's pledged to come on board to do monthly sessions about fitness and exercise, and you know he was talking about the benefits of aquatic exercise, but he spent like 15 minutes on that, and then for the next hour and a half he spoke about how do you call it, nutrition.
Oh, okay.
He
All right. I thought it was going to be mainly on the aquatics. So, all right.
who he spoke about nutrition, and for the person who's suggesting being physically active in SLE, you missed out on Sunday. Sunday we had we were discussing exercising. Someone is saying how to emotionally survive the effects of lupus. We dealt with that. We had clinical psychologist Monique Martyr last month talking about that, mental health and lupus. She would have
Now, how about kidney? Reeanna, good night. How about
Hi.
kidney involvement, Marilyn?
Hi, Marilyn.
How about kidney involvement? Somebody kidney specialist, you know, come and talk about lupus, nephritis, and you know.
Yes, I was trying to get a hold of Dr. Lynch, but I don't know. I've been having some issues getting him on.
I know the number you give me, I wasn't even getting through, but I'm working with the same thing I told you, going through this system in Mount Hope for now, you know, until I get a little relief and thing. But I would like to get more, you know, on the thing, because here she was saying about the Celiac, here she said about the Celiac, and she they don't leave no patients and no